Welcome to the Lasting Smile podcast. I'm Dr. Frank LaMar. I'm here today with my colleague, Dr. Julianne Conejo. Welcome, Julianne.
Thank you, Dr. Frank. Thanks for having me here.
And I know that your interest over the last decade has also kind of sort of paralleled mine. Tell me a little bit about your past experience.
Yeah, sure. So I'm a prosthodontist as well, and I've always been passionate about digital dentistry. Started almost 15 years ago, and have always spent time in the area of fixed ceramic restorations, but also on the area of full arch. So I think that we're in a great moment to do better quality of full arch dentistry.
Yes, our mission here at Hybridge and at the Lasting Smile is to really create clarity and take away the uncertainty that's out there, especially never in dentistry or especially implant dentistry has there been a time where technology has changed faster and opinions have varied more than they ever have today. And I think we can come at it from a standpoint of simplicity, reality, and clarity, and ultimately for the better good of our patient, which is that lasting smile.
Yeah. It's evident that in the world of crown and bridge, everything is very straightforward with the implementation of digital dentistry. But when we talk about the edentulous patient, the full arch implant prosthesis, there's so many different scenarios and so many aspects that we need to consider to be successful and efficient that I think that'll be a great conversation.
Yeah, it's been an interesting couple of years working together. You joined us here at Hybridge, as our clinical lab director. And what's interesting is that never before have we seen technology merge together with the foundational aspects of prosthodontics. And I think that's probably going to be a lot of our conversation about how do you blend, the classic aspects of full arch prosthodontics and merge that with the ever-evolving technology that's going on right now. And I think there's been quite a bit of confusion out there. The doctors that I talk to and the questions that I hear are all the same. What technology should I purchase? What is the ideal clinical workflow for full arch? What are the materials that we should use? When should we use the materials? So the confusion's never been greater, and I think it's mainly because there's just so many options. The bottom line is that most of what we do is digital in some way. We do initial records. We can choose to do them digitally, which probably 90% these days of the cases that come into Hybridge are digital captures on the front end. Although you can do an analog start. But as we go through from the start of a case to the end of a case, we now refer to what we do as a completely open workflow. Let's talk about that a little bit.
Yeah, sure. What we tried to implement was a workflow that gives you different options, because we know that not all the clinicians out there have the same equipment, the same technology, and also we want to be considerate to those clinicians that heavily invested in one technique, and how can we incorporate what they own at this point to our Hybridge digital workflow. So intraoral scanners for data acquisition, I would say it's the standard. We discussed that into detail today with no issues of which intraoral scanner they have, right? Because this is kind of to get rid of your alginate impressions with a set of digital diagnostic impressions. So with whatever, pretty much any scanner out there, we can get good enough impressions for this purpose, right?
I'll give some examples, and I can think of doctors that are some of our most prolific Hybridge doctors. They do the most arches, and I would consider them to be leaders in the field and definitely leaders in their markets. I'll refer him to my first name, Dr. Ron. Dr. Ron does a digital impression at Initial Records. He uses his Yomi robotic surgery at the time of surgery. He does an on-demand design while he's doing the surgery, and usually delivers his provisionals the next day, but he prints them in office. He waits about 6 weeks of healing. He uses his intraoral scanner and his photogrammetry unit. I think he has a PIC, and he goes to final restoration using a Generation 5 prosthetic. That's his preferred path, and that's the technology that he has in his office. He's got photogrammetry, and he has robotic surgery. I'll use another example, which somebody who has an intraoral scanner on the initial records, they like freehand surgery, so they use a non-restrictive guide. Because of that, they have to do intraoral scanning with their photogrammetry, and they print in office. And then at the very end, they go, so in their situation, they're not doing guided surgery. They want to do freehand surgery. And then, on the far end, we have doctors still who use Hybridge that are analog on the front end. They take great alginate impressions. They mount those casts on an articulator. They ask us, they have a CBCT. They want to do guided surgery, immediate provisionals same day. And then they use their intraoral scanner at the end to do their final capture. So they don't have photogrammetry. There's maybe many, many different workflows that we can accommodate to, but at the end of the day, you have your choice of technology and you have your choice of final materials at the end.
Yeah, I think that the key here is that we're giving an A to C. We're having demarcating the path. So whether you incorporate technology in different stages, we know what the sequence should be to get you from A to C in the quickest time and aiming to have clinical success.
So I'm a clinician looking to get started on a full arch case. You and I call that initial records, don't we?
Yeah, initial records. And once we are in this moment of the therapy, we have mainly two different scenarios, right? We have the partially edentulous patient with some remaining teeth in the maxilla and in the mandible, and then we have the fully edentulous patient with probably two ill-fitting dentures. So those are the main initial situations that we're facing, and I think we could review each of those two and what we'd like to do in order to get the treatment plan going.
So let's compare and contrast maybe the dentate patient with the edentulous patient, and think about it in terms of if I'm getting ready to get started, what are the basic criteria of records that we need to collect in order to do a good job?
So I think there's three key ingredients. The first one, your diagnostic digital impressions with your intraoral scanner. Make sure that you scan perfectly the existing teeth, but also as much soft tissue as possible from the upper and lower arch. And then the third one would be the buccal scan, right? And there,
which is basically the bite registration.
The bite registration, exactly. And what we are trying to get there is certain stability with the remaining teeth and scanning them both in the same image. That's the first ingredient.
Okay, intraoral scan, great maxillomandibular relationship in the most repeatable position.
Correct.
And then what's next?
Well, the next ingredient would be the CBCT, right? To get that three-dimensional image of the bones.
That CBCT has to be perfectly crisp. Patient can't be bumped in the shoulder. Your CBCT machine needs to be calibrated, and it has to be relatively new. I think the newer machines give a much crisper image, and we're relying on the accuracy of that CBCT for a lot of things these days.
Yeah, correct.
Okay, what's next? What's number? I guess we'll say what's number 3? Intraoral scan, CBCT, and what's number 3?
The third aspect is capturing the patient's face, which we can do it nowadays with a smartphone, with a portrait photo, of the patient, making sure that we capture from the chest to the entire head, and that the patient is at a high smile, or a gummy smile, as we call it as well.
Yeah, the biggest smile you got. Get that lip up there, and our patients don't like that smile, do they?
No, exactly. So, you know, I show them how I do it, so they feel a little more relaxed, and then we want to capture the lip mobility, because we don't want to have that seam from the prosthesis with the tissue visible. So from the initial record appointment, those three aspects will get the team into treatment planning and analyzing all these key aspects.
Gotcha. And then with that third component, the face, with the big smile, what do we do with that?
Well, I've been using the Hybridge app, which is very user-friendly, very efficient. So you can communicate that portrait photo with the lab using the app. Or if you have invested and you have a face scanner, you can use that as well. Make sure that portrait photo or a facial scan is sent in this virtual box, right, with the STL files of your intraoral scans, the DICOM file, and the patient's facial information.
Yeah, and the quality of all, and then we call it prosthetically driven, right, full arch, but then it's really our job to take what we see in that operatory and make sure that we communicate the parameters of what's there today versus what we want there to be at the time of surgery. And we want to be able to give our dental laboratory designers as much information as we possibly can.
Yeah, good quality information will always streamline the process and get us to the aesthetics that we're looking for.
Yes. Well, thanks very much, Julianne. I think that's a great overview. And we'll come back next and we'll talk about surgery, the next step.
Thank you.
How do we do full arch surgery well?
Great.